Good evening, everybody. We're excited to be back for the second season, the 17th edition of Webster Speaks, Dialogues on Race, Equity, and Inclusion. I'm your moderator for tonight. My name is Igo Ikakite. Tonight's episode is brought to you by the generosity of donors and supporters whose contributions support this program and other diversity, equity, and inclusion efforts at Webster University. We invite you to join them. In our first show of the academic year, we will discuss prescriptions for change, a discussion about the inherent disparities in healthcare. You can ask questions of our panelists on Twitter using the hashtag Webster Speaks, or email me at egoikakite@webster.edu. So my first name and my last name on the screen, put it together at webster.edu. We'll get to as many of your questions as possible as we can. Now, here's our host, Webster University's Chief Diversity Officer, my own boss, Mr. Vincent Flewellen.
Thank you, Igo, and welcome to Webster University. Good evening, everyone. Before we get started, we just want to say that the opinions expressed by any speaker, panelist, or participant as part of Webster Speaks represents the individual views of the person expressing these opinions and do not represent statements made by or on behalf of Webster University. The university presents this program for educational purposes and to encourage academic discourse. Tonight, in our first episode of this new academic year, we address a topic on everyone's mind: healthcare. COVID-19 has put the spotlight on the racial and socioeconomic inequalities and inequities that are baked into our nation's healthcare system, both physical and mental health. How did we get here, and what are the solutions? Tonight's special guests are the perfect experts to offer a prescription for change. Let's introduce our guests, starting with Dr. Muthoni Musangali, who is an associate professor of the Webster University Professional Counseling Department. She is a nationally certified counselor and a member of many professional counseling associations. She has co-authored books and articles related to counseling on an international level. Good evening and welcome.
Thank you, Vincent.
Dr. Jameca Woody Cooper is an adjunct professor in Webster University's College of Education. She has devoted her life to advocating multicultural counseling and erasing the stigma of mental health within communities of color. She owns a practice, Emergent Psychological Services, in St. Louis. Dr. Woody Cooper holds a PhD in counseling psychology from the University of Missouri at Columbia. Good evening and welcome to you as well.
Hi, and thank you for having me.
Thank you. Dr. Fredrick Echols is the Commissioner of Health for the City of St. Louis. He has worked in public health sector for many years, including the St. Louis County Public Health Department and the Illinois Department of Public Health. He earned his medical degree from the Boston University of Medicine, School of Medicine, and served as a physician in the United States Navy. Thank you and welcome to the show, Dr. Echols.
Good evening. Thank you for having me.
So let's start with this ongoing pandemic. A new report shows that COVID was the third leading cause of death in St. Louis County in 2020. It also says that Black residents died of the disease at a rate of almost 2.5 times the rate of white residents. What are your thoughts on that? And let's start with you, Dr. Echols.
So I'm not surprised. So I think as we report information over the course, as we've reported information over the course of the pandemic, and we presented information as if it's new. So the trends that we're seeing that we've seen over the course of the COVID-19 pandemic are not new. And what's alarming though is although we've received a significant surplus of funding through the federal government, the resources have not been placed in the African-American community as we need them to be. And so there's a scripture that my grandfather, who was a pastor, would always tell me, and it was Matthew 6:21, and says, so for where your treasure is, their heart will be also. And so what we've seen is consistent with what was happening before the pandemic, where we place resources in places where people who already have access have more access. And so those vulnerable populations continue to suffer. We place them at a further disadvantage by ostracizing them. But then when we need information for medical research, clinical research, those are the first populations that we go to obtain information and exploit them. And that has led to the distrust and so forth. So even when you place resources such as COVID-19 vaccinations in those communities, they don't trust it because of the face of who's actually providing the service.
Thank you. You know, it's again, the privileged seem to get all the resources first, and unfortunately, even at the cost of those of color and as it relates to medicine. Dr. Cooper, would you like to add anything to that? Thoughts?
I think he really summed up everything that I see in mental health as well. I also work with residential facilities, so individuals that are older, that are in nursing homes in town. And they were, again, same thing, you saw the delays with them getting the vaccine, whereas people in some parts of the metro area had them really early on. And it had a lot to do with socioeconomic levels, municipalities, and where the most money was.
Dr. Musangali?
Of course, I have thoughts about that. Very strong opinions, actually, because early on when the vaccine, first of all, with the rollout of the testing, it seemed to be concentrated in areas that most of the low-income neighborhoods could not access. And we live in a city where public transportation is designed not necessarily to promote access to some of these resources. And so people didn't have, these things were not placed in neighborhoods that people could easily access them for testing. And even when the vaccinations came around, I just remember people trying to gather, I have mentioned this before, carpooling to go to places outside of St. Louis County and the St. Louis metro area, because the vaccines were concentrated in other places and you would have to drive 3-4 hours out of the city to go find a place to get vaccinated. For many people that are low income, in low income communities, that means taking an entire day off work, finding childcare, finding reliable transportation to do those kinds of things. And so it already disadvantaged a lot of the African-American community and communities of color in this area. And so again, like Dr. Echols, I'm not surprised by those numbers. It would make sense because again, it does follow where the resources have been concentrated.
You know, I think of this when testing started, and Affinia Healthcare. I was very proud of their presence in North St. Louis, providing those free testing to members in that community. It was fantastic. So here are the latest CDC numbers on COVID vaccine. 61% of the people in the United States have received at least one vaccine dose. 2/3 were white, 11% were Black, 17% are Hispanic, and 6% were Asian. In conclusion, also follow up on that, 5% identify as multi or another race. What do you think of this disparity, especially among Black people and whites? And are Black people getting vaccinated in greater numbers locally?
I'll start with that one since we're at the forefront of vaccine distribution for the city of St. Louis. And unfortunately, what we've seen in the city of St. Louis is a similar trend. So when we look back to, go back to January and February of this year when vaccines were first available for population, what we saw was a greater uptake from our Caucasian population in the city of St. Louis. So the Caucasian population as well as the Asian population really had greater uptake from the beginning all the way through the middle of the year. And so African Americans have lagged behind for several months. And not until recently did we really see an uptick in African Americans receiving the COVID-19 vaccine. And that's a very complex issue. When we talk about lack of confidence in medical products, we have to think about, again, the history of health service delivery and clinical research in our communities. We know that particular communities in North St. Louis and some pockets of South St. Louis have been exploited over time. And there's been a great level of disinvestment, not only from city government, but also from some hospital health systems, as well as clinical organizations in the city of St. Louis. And so there's been a history of trauma amongst the predominantly African-American populations. And so although we have this life-saving tool, which we the COVID-19 vaccines that are available and are provided at no cost, the history of trauma is really an issue for our community. We're at a point now when we look at the health county rankings, and particularly in the city of St. Louis. So back in 2019, although there are roughly 115 counties in the state of Missouri, in 2019, according to the Robert Wood Johnson Foundation, the city of St. Louis, who has probably more medical providers per square mile than any other jurisdiction in the state, ranked 112th out of 115. Right? So that's alarming. And so, because of the history of trauma, people are not only not willing to access services, but they're not willing to accept some of the resources that we're providing or that we've made available that can really help protect their health and help them achieve optimal health. And so that's really a problem for us. So we have to really understand where our communities are coming from. I think there's a lot of push, a lot of messaging around just achieving herd immunity or getting up to 70%. That was the focus. Everyone's talking about herd immunity without focusing on the trauma that these communities have endured for several decades. And so our approach in the city of St. Louis was a little different. So we really focused on making sure people had accurate information. Then we also gave the community platforms to be heard. So we allowed them to opportunities to share their concerns, share their issues that they have related to SARS-CoV-2 and COVID-19, as well as the COVID-19 vaccines. And we took the time to really answer those questions so that they can make an informed decision. One thing that has been lost over the past several decades, or actually century, is, for minority populations have lost that ability to haven't been empowered to be their own health advocates. And so the way we do that is by providing them with accurate information in a way that's culturally and linguistically appropriate. So we have to be mindful of the trauma that has been caused, that has resulted in those communities, and acknowledge that up front. That's one thing that we did, as well as we started having these community discussions. The first thing we would do at the beginning of our meeting is to acknowledge the harm that our agency, even if we weren't in this space at the time, our agency has caused harm to the community. So acknowledging that up front really set the tone and really allowed our community members to understand that we're not here with any hidden agendas. We're just really here to give you accurate information. But unfortunately, what we're seeing, similar to the information you provided in the statistics, we still have a lower uptake for the COVID-19 vaccine amongst the African Americans in the city of St. Louis. But again, that's not just unique to COVID-19. When we look at other immunizations, that trend has been in place, has been persistent for several decades.
You have used the word trauma a couple of times in your explanation there. And I think that for some of us, it might be a new lens or a new way of thinking of trauma. Can you talk a little bit more about trauma in terms of definition as it relates to this topic?
Absolutely. So when we talk about trauma, we're talking about any harm, whether it's intentional or unintentional, that is caused or placed upon a particular population. And so a good example would be, we're talking about healthcare, so we'll talk about the evolution of the health system and the health service delivery in the city of St. Louis. So most people are familiar with the hospital system. There was hospital number 1, there was hospital number 2. Then there was the Connect Care, but there was poor planning, and what ended up happening was those valuable resources that were put in place to provide health services and medical homes for our most vulnerable populations were stripped away. Not only that, a lot of those services were moved to the health department, but then within the health department, at the start of my tenure as the director of health back in 2019, we had 84 employees that were responsible for implementing over 15 public health programs for a population of over 300,000. That is not sufficient. And so we've also seen that within local government, there hasn't been proper advocacy for public health. And so what we've seen over time, over decades, is that you have had a dwindling of the public health infrastructure. And then when there's a public health emergency or emergent situation that's impacting the lives of our residents, then everyone wants to put all the work on the back of public health. But we need to make sure that we're properly supporting our public health infrastructure consistently, not only in times of emergencies.
Said a lot there. Dr. Cooper, do you have any thoughts in terms of those numbers on the COVID-19 vaccine in terms of the disparity that it presents?
Well, I would add that I still see the same numbers. I don't know that it's increased a great deal in the St. Louis area, because I guess I work with the patients on the other side of that, so for the mental health purposes. So basically, I spend most of my days arguing with people about the vaccine and why it's necessary. And most of the times when I'm dealing with older African Americans, they're often the sickest of us all and the ones who need the vaccine the most. But those are usually the ones that are the most adamant about it, for a lot of the reasons that Dr. Echols just said. So what I found in working with my patients in the midst of this pandemic is that a few things are going on with them. So why are they voicing their concerns and being so adamant about not getting the vaccine? So one is they want to be informed. So like Dr. Echols said, we have a history in this country of not everyone from marginalized groups feeling like they are a part of the process, right? So my patients want to be informed. They want to have a voice. They want to show that they have a voice in their own healthcare, and they want to be part of the choices. They want to have a voice and make their own choices. And so for a lot of them, I end up telling them, like, I get it, I hear you. This is not the time or the issue in order to exercise these things. There are lots of other things you can do that on. Let this not be one of them. And like Dr. Echols said, they feel the same way lots of times about the flu vaccine as well. I'll have people that proudly boast and say, well, I've never had the flu vaccine either. And I say, well, that's a shame, because in the elderly population in long-term care facilities, it runs rampant every year. So why would you not receive the vaccine when it's available to you? So there are a lot of issues about historically what has gone on in our community and what has not happened.
I absolutely agree. And thank you. Well said there. So Dr. Musangali, what do you think about the COVID numbers and how it's affecting us today?
I have a slightly different perspective. I look at these numbers and I don't have the same access to the same kind of information that Dr. Echols has, but I look at the numbers here. 2/3, Vincent mentioned that 2/3 of those people that are vaccinated are white, which would be about 66%. And when you think about the distribution of the general population, white make up about 70% of the population. So that number, there's not a great disparity there. 11% were Black, and there's about 13% of the general population that is African American, 17% Hispanic, which corresponds to about 18% Hispanics. And maybe those numbers are what they are now. One thing that would be interesting to look at is how those numbers have evolved over time, so that we see the uptake increasing over time, which is a result of the efforts that Dr. Echols is talking about, which is really purposeful and intentional education efforts that are culturally sensitive, that people may have been hesitant at the beginning. And that hesitancy was then taken and blown out of proportion as African Americans don't want to get the vaccine, when in fact, hesitancy or reluctance is not the same as refusal. They're not anti-vaxxers. They're not saying, I'm not going to get this, but I want to know what it is. I want to know how it's been arrived at. I want to know, certain things about this vaccine, and then they will go on and actually get vaccinated. So I think I'm just wary sometimes of looking at those numbers and thinking that our people are not getting vaccinated at the same rates, and then thinking that they don't want to get vaccinated, because that's not necessarily true. Because I think we're using that sometimes to excuse a lack of effort on the part of organizations or institutions to ensure that the masses are educated, and that the education efforts are culturally sensitive, using, culturally and linguistically sensitive, so that we can increase the uptake. So people aren't saying no, but we have to find a way to get this information to them in a way that they will actually receive it, because I think they want to get the vaccine, but they want to know that it's safe. They want to know several things. And why would we not share that information in a manner that increases their likelihood of getting vaccinated?
I agree. And it's a valid assessment, because I would like to know, before I take something, what's the effect? Do I know somebody or a close friend or my doctor friend that's had it already? And what chances do I have to be okay by taking it? So information is powerful. Information is key in doing that. So there's a widespread perception, that this hesitancy among some in the Black community to get the vaccine is tied to a very shameful history in our time. In our time, but in the nation's history, the Tuskegee study of 1932 to 1972. For those who don't know what the Tuskegee is, it was a U.S. government study of untreated syphilis. The subjects were 400 Black men in Tuskegee, Alabama, and the study lasted from 1932 to 1972, such a long time. And the subjects were not told about the disease and were denied penicillin to treat it. More than 100 of them died. So the question is, to what extent did Tuskegee influence Black people's attitude towards biomedical science? And of course, the COVID vaccine versus the disparity in the access to healthcare and the quality of healthcare. Dr. Echols, you want to go first?
Sure. So one of the challenges, even with the Tuskegee experiment, there was exploitation that occurred. But even within the African-American community, there was misinformation that was shared about the Tuskegee experiment. And so that led to members who actually lived through the Tuskegee experiment partnering with an agency to issue a video that was released during the pandemic to really highlight exactly what happened. Unfortunately, what we have also learned over the course of the pandemic and continue to learn is that bad information, misinformation gets legs and it walks really, really fast and it spreads like wildfire. And it's really difficult sometimes to address that misinformation before it spreads too widely. And so we have to really double our efforts to make sure every segment of our population, from those who have and those who have not, have access to accurate information so they can make informed decisions. And unfortunately, Tuskegee is only one of the events or research projects that adversely impacted minority population. There are other examples of exploitation of minority communities going back as early as a few years ago. And so we really have to make sure that we're doing our due diligence to make sure that individuals know what actually happened during these particular projects and also what steps were taken to address those issues. So since the Tuskegee experiment, the federal government has implemented additional restrictions and regulations to protect those who participate in clinical trials. And unfortunately, that information doesn't get into a lot of the communities. And so as a health department, as well as working with federally qualified health centers and hospital systems, we have a duty to get that information out as widely as possible as well, because one of the other challenges, with that has resulted from the Tuskegee experiment and other clinical experiments is that minority populations are more hesitant to participate in clinical trials, even when they had difficulty recruiting minority populations for the COVID-19 vaccine trials. And that really handicaps us from a medical standpoint, because it oftentimes, when clinical trials are being conducted, that gives them an opportunity to see if a medical product is going to adversely impact one particular population different from another. So we're able to really identify these different issues before the products are made available to the general population. And so although significant strides have been made to increase minority representation in clinical trials and clinical research, we really have to do a better job of informing communities about what the project entails and also what protections are in place to ensure that if they are harmed or if harm does happen, there are mechanisms by which they'll be protected. And so those things are really critical. One thing that I found when I started in Missouri was that we were signing up individuals, or people were being signed up or enrolled in clinical trials or studies, but there wasn't sufficient communication. So when typically, when you go get a product, you want to know what the product is. You want to know what the product is going to benefit you in your livelihood. But that wasn't really communicated to the participants. And so one of the things that I started when I was in St. Louis County was we started mandating that individuals receive information in plain language up front before they enrolled in the study, so they can understand the need for the study, as well as how their participation could help inform local public health and medical practice, as well as national public health and medical practice.
Oh, thank you for that wonderful explanation, because it's good we know in details. And yes, people do have reservations, except until they get the true information on what is really going on to our community, then we can go ahead and begin to believe this test and all of that. Before we continue, Mr. Vincent is having some technical issues and he will join us pretty soon. Dr. Cooper, what do you think about this whole Tuskegee experiment and how it affects us today?
I think it impacts our community a lot. You hear those words being said a lot as it relates to COVID and the vaccine. I hear it probably almost daily with my patients. And I think what is going on is that was real. The Tuskegee experiment, that was real. That's rooted in fact. It's not myth. It's not fantasy. We also think about Henrietta Lacks and the fact that her cells were used without her knowledge and consent, and her family is still fighting that today. So these things are rooted in fact. So there's clear evidence and a pattern of mistreatment to the African-American community and other marginalized communities as well. So they have a right to feel the way that they do. What the issue is they need to have the information, like Dr. Echols said, if they were provided accurate information on clinical trials, on what about follow-up? Do I need to get a booster? Those type of things. If they really understood how COVID-19 will impact their health, given their pre-existing conditions, many of them would probably rush to get the vaccine. I spend a lot of time explaining to my patients, like, you have high blood pressure, you have diabetes, you're likely going to die if you get COVID. You don't have what it takes in your body to fight this disease. You have too much inflammation. If you have an autoimmune disease, that's a no-brainer. You really have to get the vaccine. So when I take the time and explain those things to them, they're really on board. So I will agree with Dr. Echols. It really is about communication. It really is about acknowledging what their concerns are. It really is about taking the time to explain the long-term health consequences of COVID, of the vaccine, and other vaccinations in the past. I think people really don't get the connection between what they need versus what they hear. And it's hard for people to tease out, what my neighbor said is right versus what is really scientifically right sometimes.
Well, thank you for that. So, Dr. Musangali, do you think that today people use Tuskegee as an excuse to provide inferior healthcare to the community of color because, oh yes, they don't believe in testing, so let's give them something inferior? Do you think Tuskegee is an excuse that providers use today?
I think that's an interesting question, Ego. Tuskegee, I think the perception varies depending on what side of that of the coin you're on, whether you're a consumer of health services or a provider of health services. I think that there is an extent to which on institutional levels that has been the basis of, I don't know what term to use. I'll say lazy, because that's probably more polite than anything else I can think of. But a lack of innovation in terms of thinking how to reach people, and that the easy thing to fall back onto, that's an easy scapegoat, is Tuskegee. So we know about Tuskegee. It's 40 years, since 1972. It's been quite a while that we keep coming back to that place. We know the impact that had on attitudes towards medical health and care. And up until then, what are the efforts that we have put in place to address that, to combat the misinformation? I think that's what Dr. Echols is speaking to, what Dr. Cooper is speaking to as well. And the messenger is as important as the message, sometimes even more critical. So when Dr. Cooper talks about her patients, her clients that she's working with, she has earned her trust. And so she's a voice that they trust. She has taken the time, she has invested that time and energy into building a relationship that of trust. And therefore, when she talks to her patients about it, they're more likely to receive that message. In the same way, we have to be innovative in how we're doing these educational approaches. So talking to our communities that are suspicious, because true, there is suspicion, there's fear and uncertainty about based on the impacts of previous clinical trials that have gone wrong, that were not always done right. But then who is the messenger? So it's not just about going in and educating people and giving them information to correct the misinformation. We have to be really thoughtful about who are we asking to provide this information? Who's going in? Is this that the people who have gained, first you have to build those relationships and gain trust so that then the people will listen. Sometimes you don't even have to explain a whole lot about, I have found it's not so much as what is in the vaccine as where is it coming from and are these people that we can trust? So it's the idea of mistrust of the system that affects people's decision-making. So having to think about innovative ways to provide this information and utilize informal authorities within our own communities that already have that relationship rather than bringing outsiders, because then it's really a futile effort for the most part.
Yeah, so talking about that relationship and who can bring it, does the Black church, which we know is very influential in our society, do they have a responsibility, or what role do they play in attempting to get people vaccinated?
I'll give a quick example. So I'm a member of a large Kenyan community here in St. Louis. We have some Kenyan churches in North County, and they have been the site of some of the vaccination efforts that we get a message that goes out to the people in our community, not just Kenyans, but the African community in general here, that says this is happening at the church. If it is happening at the church, then it comes with a certain level of endorsement. And people then don't have all of those questions where they might have feared and being untrusting, they're more likely to come. So absolutely, they do have a role to play, and working in collaboration with health officials in the community, I think that that's a really important partnership, not just about the COVID vaccine, but about a lot of health issues that affect the Black and Brown communities here, that we have to recognize the hierarchy of power and authority in our communities and utilize that to our benefit and to the benefit of the people in those communities.
Oh, thank you so much for the follow-up question. That was my own personal follow-up question for you, so thank you. I'll just, next question I have, it's one thing we can't forget is that racism in healthcare does not exist in isolation. It is a symptom of racism that runs through the entire system, from healthcare to school to education to job and so on. So let's talk about how that works. How do you think it works, running racism and healthcare in of itself? Dr. Echols, if you want to go first.
So it's become part of a culture, and I think, unfortunately, the way it's presented in the media is sometimes that we have these one-off situations. So, for example, during the COVID-19 pandemic, there have been a few reports of minorities seeking health services through emergency departments, and they were essentially dismissed. And in some cases, they ended up dying either in the parking lot or near the facility. And we have several reports of individuals who've developed COVID-19 disease and asked for specific treatment, which was denied, and they end up dying later as well. And so, unfortunately, what we are seeing is that this is that the bias and the racism has really become a part of medical culture. And so that's something that, oftentimes we look to see how that manifests in our communities. And it manifests itself in our communities by the disparities that we see. So when the person, regardless of their educational attainment and economic attainment, has a higher risk of dying compared to another population, that is really concerning for us. And so one of the things that we have to really do in our health systems is make sure that we are preparing the next generation and continuing to work to get the current system of medical providers to a place where they can recognize their own bias, recognize how racism works and how it works to disadvantage certain populations, but also work to ensure that they're able to deliver health services in a culturally sensitive manner. And that requires some level of humility, but also requires a lot of dedication, because we now understand that the culture of the United States has been built on racism. And so really undoing a lot of the damage that has been done is going to take some time. It won't happen overnight, but I think we have an opportunity to really start undoing some of the damage. And the way that we do that in a sustainable way is through policy. Evidence-informed, sound policy is really what we need to sufficiently address the issues of racism in our community.
Yeah, thank you for that, Dr. Echols. And personally, I think being able to get a seat on the table as well, too, is essential for us if we truly want to see that change in of itself in the system. Because anything institutionalized needs we, the people that have the same skin color, to go there and eventually make a difference. There's more hope. There's more when you've experienced something, when you've lived through something. There's such a passion that you would have to make a change. Dr. Cooper, what do you think?
What I will say is that, yes, what we see in healthcare is really a symptom of the larger issue, which is called systemic racism. You could really continue. There's lots of years and decades of generational systemic racism, trauma, and we see it in all areas, especially in a city like St. Louis, where it's quite segregated. You can look at education. The educational system in St. Louis, K through 12, is one prime example of how that works. And if you're someone who's lived in St. Louis for a long time, you know what that means. You know that you have to either live in a certain part of town so your children can go to the right public school, or you're going to have to be able to pay for private school somewhere. So it's clearly about how much money you have in that case. So what we are dealing with now in light of COVID is that these same people who've been told their whole lives, you cannot go to school here because you don't look like, or you don't have what you need to have, or you can't work here because you don't look like or have what you need to have. So now they're being, what they feel like is being forced to get this vaccine. They're like, wait a minute, so this is all coming from the same place. And they don't trust the origin, they don't trust the message. But if we could get people that look like us into these communities to talk to them and provide that information, then that would be different. They would feel different. They could possibly receive the message better. So I think it is all really tied to the systems of racism and white supremacy that we see all over this country.
Thank you. I'm going to just rejoin this as a guest. Ego, I trust that you have been doing a very great job in leading this conversation, and I don't know where it has been. I apologize for the technical issues I've experienced. I'm glad to be back. Heart is slowly slowing down, but it's slow. Ego, so you take it on, and I will just be
okay. So yeah, Dr. Musangali we're talking about the systems of racism and how it affects the healthcare itself. So we've had Dr. Echols speak, Dr. Cooper, now Dr. Musangali would tell us her opinion on that aspect.
Sure. In agreement with my colleagues here, that healthcare is, the racism in healthcare does not exist in isolation. Absolutely. It's an extension of the racism that exists in all other systems that we encounter, whether that be housing, education, employment, all of those aspects impact healthcare as well. And so when we have racist policies and practices in the practice of in the delivery of education in our school systems, for example, that's going to impact health outcomes. When you think about the social determinants of health, people are likely to stay in low-paying jobs, and as a result, then they may not seek the help they need. They might not have health insurance. They don't have access to medical care. They don't have access to dental care. They don't have access to mental health care. They don't have access to transportation to get to places where these things are offered. And then we have found that those services, again, are concentrated in areas that are outside of the reach. And I'm really pleased that we have a seat at the table. I think that's why I'm so thrilled that Dr. Echols is here, because when you talk about policy, that we can't shape policy in absentia. We have to be present so that we are there when decisions are being made, and we can make sure that those decisions that are made are favorable to us. So it's about also going back beyond the healthcare system and looking at the education system. I'm passionate about the transportation system. I feel really strongly about the education, the public transportation system in St. Louis. I have not lived in a city that was like this. I have lived in St. Louis for 8 years now. I don't get it. I don't get why I can't get on a bus in the city and come to Wentzville, which is just 40 minutes away. There are things I don't understand about this whole setup. I'm sure it's designed with some reasons in mind. Those reasons are not for our benefit, and they go into also ensuring that people don't have access to mental health care and medical health care as well. So we cannot speak of medical and mental health without talking about all of these other things that are so closely intertwined. When schools are funded on a tax base that is based on a segregated city, right? And so your resources in one school district or one school building are markedly different from resources in another school district that's just 3-4 zip codes away. Until we address those kinds of things, we really are going to have a very hard time moving the needle on healthcare as well.
If I can add one quick thing. So
sure, please.
Oftentimes we talk about having a seat at the table, and I think everyone agrees that that's really important. But one thing that happens, particularly for minorities, so oftentimes we'll have the seat at the table, but we don't necessarily understand how the system works. And so then we begin to sign on to policies that perpetuate the same issues that we claim we want to address. So it's really important, before either while you're at the table or before you have a seat at the table, make sure you understand how systems work. So there's several systems within government, the health systems, education systems, correction systems, that all work to disadvantage certain populations. So if you don't understand how those systems work together to further disadvantage population, and then you have the whole issue of intersectionality. So even if you're a woman, you may be further disadvantaged than a man, than a male. We have to understand how the systems work so that we can make sure that we aren't doing more damage to our own population, to our own individuals who look like us.
Well, thank you so much for that, Dr. Echols. I'll just bring Mr. Vincent in with regards to what we're talking about, racism and in healthcare not being in isolation in of itself. Has there been a time in your experience, whether here in St. Louis or around the country, that you faced an experience with maybe a medical practitioner or a doctor with regards to racism, and how did it make you feel?
So none in terms of the direct piece of racism, but I have had an experience recently by going to visit my doctor for my annual checkup, and the blood results, we were going over the lab findings, and the report that actually came into my chart first had like an asterisk, and then I went down and read it at the bottom. And basically it talked about the fact that the findings on that particular lab piece as it related to actually testing of kidneys was had the lack of race. Black folks had not been a part of that study. And there was a note that said that the interpretations for Black folks is slightly different, and that those, the Kidney Association and the Medical Association were redefining that. And so my doctor also then explained that to me too, and immediately told me not to worry about that part. But that is that indirect but direct piece, right? And if I had a doctor who didn't explain that, or if I didn't go down and read and was curious enough for myself about my history, or if I couldn't read, right, like I would have missed out on some information potentially.
Oh, well, thank you for that. Does anyone have a response to that? Or okay. So we.
I do.
Okay.
I've had experiences very recently, actually. I've had instances. I'll tell you about one example. I was playing tetherball, and I injured my finger. It like sort of went back this way, and I was in excruciating pain. And I went to an orthopedic doctor here. I went to several doctors' offices, and I kept getting referred from one place to another. And I finally went to the place that I thought was the place I was going to get help, because it was the final referral that I had. I remember going in there, and he sent me away and told me to go get Tylenol and take 2 Tylenol. I was in so much pain, people. This was like 10 days after I'd had that incident, and I still couldn't move my finger. And I was in a lot of pain, and I knew that I needed something more than that. And I remember going back and sitting outside after I had gone to this doctor. I had to wait to see him. And when I finally did see him, he was barely with me for 2 minutes. I kid you not, he was with me for about 2 minutes. When he left the room, I sat there in disbelief, because I felt you really couldn't, I didn't understand. And I left that room and I went and sat in my car and I just broke down because I was very sure that if my skin color were different, I felt sure of this, I might be mistaken, but my perception at the time was that if my skin color was different, if I was not a Black woman, that he may not have minimized my experience of pain and what I was reporting, that he'd have taken more time to speak with me and find out what my experience was and see how he could have helped me. I ended up, it took about 3 months for this to heal. I couldn't really use my right hand. I could barely wash my body. And I have always thought of that experience and felt really angry about why was I treated that way? What if I had been Vincent? What if I had been Dr. Echols, maybe a man? And that's the idea of intersectionality. What if I was not a Black woman also, right?
I want to add to what Muthoni said. It unfortunately, it goes very, very deep. There was a study done a few years ago looking at the attitudes and beliefs of medical students and residents. And what they found in that study was that those students felt that Black people have thicker skin, actually thicker skin than white people. So if you can extrapolate from that, if we have thicker skin, that also means we experience pain to a much lesser degree, right? So that directly goes into what you said and how they perceive our suffering, or if they perceive our suffering. You see lots of times, a lot of anecdotal information and research that says that doctors don't offer pain medicine to minorities, especially African Americans. And if they do, it's to a much lesser extent. And I get this a lot. I hear my patients talk about the medicines they've been prescribed. They might get 60 pills of oxy, whereas a Black person will go in and get 5 for the exact same thing. A Black person will have surgery and get less than 3 days worth of any of those pain medicines. And so the assumption is that we don't experience pain in the same ways. So if you look at that globally, so it's not just physical pain, it's also mental pain, right? So we don't have PTSD, we don't have trauma. We're not depressed. We're not anxious. We don't have insomnia because we don't suffer in the same ways that other groups. So that can really be looked at in so many ways. And I see it, especially in my field with mental health. I'll see people that have been seen by 5 other counselors or psychologists, and they get to me and they'll say, no one has ever told me I have PTSD. And I'm thinking, this is obvious. This is an obvious case. You should have been on this, that, this should have happened. No one has ever brought that up to them because they don't experience pain. If you don't experience pain, you definitely don't experience trauma.
Well, thank you for that. I'll just say this real quick. My own experience. I had the black widow spider bite my hand. My hand was swollen, went for surgery, and the doctor said, you have a very thick skin. What's going on with your skin? Where are you from? And I'm like, I felt really, really bad because for you to say my skin is thick means I'm different, but I ignored it and I just kept on, going and allow him do his job. But we see these things, and even though we don't say them at that instant, we go back home and we reflect on them, and it has some issues in us, affecting us, and we feel bad, and it's reality. So I'll just say the next question I have: a recent viral story follows the story of a Black physician, Dr. Susan Moore, who documented her COVID journey on Facebook. She described subpar care at 2 Indiana hospitals. Even though she was a doctor herself, she said her treatment was affected by her skin color. Her complaints of pain were ignored by her white doctors. She was made to feel like a drug addict for requesting pain medication. She had to convince her doctors that she was having breathing problems, just like what we've heard today from Dr. Musangali and Dr. Cooper. She said in one video, I put forth and I maintain that if I was white, I wouldn't have to go through that. Dr. Moore died at age 52 on December 20th, 2020. What do you think about that? That's a very sad story, but we've heard this from Dr. Musangali today. But what do you just think about that story? I'll start with Dr. Echols, please.
It kind of, really is an example of what we've just been talking about. Mm-hmm. So this perception that African Americans and minorities are super beings. We feel the same pain that you feel. We have the same hurt that we feel. That you feel. We have the same risk for addiction and all these other issues that our white counterparts have. And so it's really important for them to understand that we're human. That's it. So we need them to understand that we're human, and that we are susceptible to issues, injuries, et cetera. And, we can talk for days about reports of individuals who haven't received appropriate treatment. I think every one of us probably has a family member that hasn't been treated appropriately. For me, it was my father who had to seek 5 consultations before he was diagnosed with having a heart attack. And we were lucky that he's still with us. But the fact that he had to seek multiple care from multiple physicians before they actually took the opportunity to even do an EKG, that's a problem. That's a problem. It's part of the culture. And I think, we really have to start early. And when we talk about other issues that impact the African-American community, whether it's gun violence, everything is connected, as Dr. Musangali said. So we need to really have a comprehensive approach, but we also have to really start working early, start working further upstream to train the young people that are coming up. Let them know, hey, one, mental health and behavioral health, there's nothing wrong with needing help. If you have issues related to health, there's no issue being a good health advocate for yourself and teaching them how to advocate for their own health. Those things are really critical, and we have to start doing a better job of working upstream. And so the City of St. Louis Department of Health, we've been working closely with all of the school systems in the City of St. Louis, but we have a long ways to go. But as with everything, we have to start somewhere.
I agree. Thank you so much. Dr. Woody Cooper and Dr. Musangali, I know you both have exciting news to share about the Webster University and how Webster is addressing these issues. So I'll give you both an opportunity to talk about it. But first, let's explore the aspects of mental health and why more Black people in particular are not receiving the mental health treatment. Dr. Cooper, if you would go first, please.
Okay. Before I say that, I'm going to bring it back around to what we were just talking about a minute ago, because I do want to add a story to bring it back to St. Louis. I had both of my children here in St. Louis in Barnes Hospital. And when I was pregnant with my second child, I went into labor early. And so I went to labor and triage at Barnes, right on Kings Highway. And I was in active labor, but because I was only 27 weeks along, they didn't believe that I was in labor. Although I told them I was in labor, because this is my second child, right? My husband, so my ex-husband now, but my husband at the time was an ER doctor trained in that same hospital, in that very ER, who was with me, telling them that I was in labor. And they were like, oh no, she's not in labor. So long story short, they had to rush me in for an emergency C-section. My son was born 13 weeks early at 2 pounds, but only when my water broke did they believe, wow, she's in labor. So despite what I was telling them and what my husband, who was trained to do what they're doing, told them, who had supervised some of them, told them, they didn't believe me. So in this country, we know that Black women are 243% more likely to die in childbirth than white women. These are rates that are worse than in an underdeveloped country. So this is the country that we live in, but these are the numbers we have. So it does come all the way back around to mental health, because if you know and you feel deeply in your soul that you're going to be mistreated, overlooked, and minimized, then first of all, would you even go? Second of all, if you go and they tell you to do X, Y, and Z, take this, are you going to take it? Because there is no trust, there is no relationship, there is no honoring of each other's existence in that experience, and that's what we're missing.
And that's really powerful. So there's this culture that has been created in African American and minority communities, where people would rather suffer at home than to access care at a health facility, because they feel that they're going to get killed. That's the truth. And so when we think about why we need other services such as doula services and other culturally sensitive or culturally appropriate services, the reason that why we need those services is because the current services aren't meeting the needs of our people, and our people continue to die at alarming rates.
I do wonder though, in terms of the medical school, right? Like, it seems as if much of this could be, if we had transformative curriculum redesign and shifts to really talk about race and those inequities, would that not begin to help prepare and send out practitioners who would then not have such a racist thought that Dr. Cooper just explained that led to what really could have had a much more tragic and much more traumatic result?
Absolutely. So that goes to working upstream. So making sure that anti-racism, anti-bias training is incorporated into medical school curricula and even pharmacy curricula, because sometimes pharmacists have the same bias and the same issues that some medical providers have, as well as making sure that providers understand, as I talk about the evolution of health services for the United States, but particularly in the area where they're serving. So when we think about how health services has changed over time over the last 6-7 decades in the city of St. Louis, it's not a pretty picture. You know, we have minorities who are treated in the basement because people didn't feel like they deserve to be treated on the floor. That's something that we have to acknowledge. I think it's something that's a story that needs to be told. So our medical providers are well informed that when your patient comes in and they feel like they have a chip on their shoulder, there's a reason for that chip. And so by implementing trauma-informed practice and meeting the patients where they are allowed, creating a space where they feel safe and they feel comfortable sharing their most intimate issues with you is really important, because everyone wants to feel valued. Everyone wants to feel like they're human.
I agree. Well, thank you, sir, for that. So Dr. Musangali and Dr. Cooper, so we don't forget the program you have at Webster University that handles this. You want to talk about it? Dr. Cooper, you want to go first, please?
So yes, we have a new graduate certificate in the School of Education at Webster called Race and Racism in Psychology and Education, and it will launch in spring of 2022. And the impetus behind that was that after years of teaching students from all backgrounds, I realized that students who are in psychology, who are training to be clinicians or teachers in psychology or educators, who we teach a lot of teachers at Webster, none of those people have ample education in race and racism, but yet they're being sent out into K-12 schools across the country without that knowledge. So then we expect them to act fair in a fair way to students from these backgrounds, and they are not able to do it without the right information and the right knowledge. So it's a new graduate certificate, one, if not the first, one of the first in the country with the emphasis of such. So we're excited about it. And we hope to really train students, graduate students, who are going to be social change agents in whatever areas they end up working in.
Sorry, thank you so much for that. That's a good one. We look forward to it. Dr. Musangali, please.
Yeah, so we recently were awarded the Department of Professional Counseling at Webster University. 3 faculty working in collaboration with the rest of the faculty in my department awarded a $1.2 million grant it's the Behavioral Health and Workforce Education Training grant through the Human and Health Services Department. And we are working to improve and promote access to mental health care by sending students who are in the Webster counseling program to do their practicum and internships in areas that are designated as health professional shortage areas, HPSAs. The locations where our students are doing their practicum and internship have to have a score, an HPSA score of 16 and higher, which means that they are high priority. They are health professionals designated as health professional shortage areas. An example is we have students at the St. Louis County Department of Public Health, where people are coming for medical health issues. As we've seen already, like there are so many barriers to accessing mental health treatment within our communities. So ensuring that providing mental health in the same setting as medical health interventions, so that when people come for medical health issue, then they are also assessed for mental health issues. And we have a student working with the county staff to provide those services and follow up. People are less likely to go, like Dr. Echols said, they're less likely to go seek help for a mental health issue, but most likely might go, even with some reluctance, that they may seek help for a medical issue. So while they're here, then we work with the staff there to do an assessment and then refer them to mental health providers who are our students who are working under the supervision of the staff there. But we also have other locations in the county that we're working with and in the city as well, all of which qualify as health professional shortage areas. The goal really is to integrate, because we cannot separate. Mental health is really critical, and it's an integral part of medical health and health in general. So providing those and promoting access and bringing the services to where the people are, rather than having people then go out to try and seek mental health counseling for themselves after the fact, because they're less likely to do that. Working to prepare students so they're competent. We're going beyond the classroom and talking about cultural competence. We have a cultural foundations course, which is great in theory, but we are immersing our students in these places. It doesn't have to be African-American students, our white students, our Hispanic students, our Asian students, but it's the idea of really preparing them so that they're competent, and upon graduation, they're more likely to stay at those locations and continue to provide care even after they have graduated. So the hope is that we will increase a competent mental health workforce that will help to meet those the need in those communities. It's a 4-year grant. We're just in our first year, and we have 8 students right now, looking to add another 3 in the month of October, between October and December, and we'll have a steady stream right up to 2025. So we're very, very excited about this.
We're very excited as well, and for both of these wonderful programs and projects that will work to improve the lives and the health of people of color throughout St. Louis. As we bring up Dr. Schuster and Strobel, President and Chancellor respectively, I want to just read, we had a comment that came through. Dr. Cooper, that is great news. I worked in the School of Education, and I believe the new certification program is long overdue and will be a great asset to the individuals who come through the School of Education.
Thank you.
Thank
I
you.
hope so too.
Dr. Schuster and Dr. Strobel, welcome tonight.
Good to be here.
It's been a night, hasn't it?
It has been a day, but certainly a night at this point.
Well, I think that we should start by congratulating Ego for a spectacular job moderating this conversation. Thank you, Ego. And Vincent, the two of you are an unbeatable team. We look forward to the coming episodes and the work that you're doing together. And I certainly want to congratulate Webster colleagues for not only, along with Dr. Echols, and thank you for joining us tonight, not only identifying what the root causes are and helping us understand the current state, which is truly unacceptable and should be unacceptable to all of us. But then, as the title of the webinar and tonight's episode said, starting to prescribe what the change needs to be. And actually being agents of change and empowering more agents of change. And it's exactly what's needed. It's sobering to listen to how exclusionary, and most of the time purposefully exclusionary, programs and practices and policies have been, and so destructive to fellow human beings. It is sobering, and it should prompt all of us to want to be part of a prescription for change. I will just reflect a couple of places that your wonderful conversation took my thinking. I've been trained as an educator, and 2 authors whose work was enormously influential in my commitment to equity were first Herbert Cole in 1991, talking about how learners have to assent to be taught, that learning is voluntary. And feels very much like the realm of work that you were talking about tonight, is that to choose to have a vaccine, to choose to trust a practitioner and the information is an active choice, and to treat it as otherwise is disrespectful. And learners can choose to fail simply because they don't give us an assent to learn from us. And it is part of a broader culture and a broader reality. And certainly Jonathan Kozol's Savage Inequalities talks very strongly about this and how structures and systems are purposefully built to make sure that resources are differentially available and applied. And you've given us rich and sobering example of that. Ego and I, and Vincent to a different extent, have been part of a global conversation about this, as has Jameca. And we've talked about the fact that when we look at the continent of Africa and think about the access to vaccines there, many people that have hungered for vaccine, and it's truly not been available. And how landmark an achievement it is to the continent of Africa and many others that there will now be a malaria vaccine. So the global dimensions of this issue certainly echo very strongly on the St. Louis-based conversation, and the St. Louis conversation being an indicator of a larger reality of inequities and access and treatment. And then I'll finally close and hand it over to Julian, a book that I'm reading with another group of Webster colleagues. The shorthand title is The Barbary Plague by Marilyn Chase, and it documents what a struggle it was to deal with the bubonic plague when it came to San Francisco in the early 1900s, and populations that were targeted for treatment, and other populations that were scapegoated because they were seen as the cause for the spread of the plague. And human nature, regrettably, and bias and systemic ways of treating populations was very present then, and in some ways, as you say, has not changed. So I'm eager to be supportive and a part of solutions that Webster is starting to enact because it's long overdue, and I'm glad we're part of trying to deal with something that we should not abide as the human community. So thank you for tonight. Thank you.
Thank you very much. You know, I am sorry I was a little bit late. I did have a double booked on the College of Arts and Sciences Advisory Board, where I did speak about Department of Professional Counseling, their grant and their good work that is commencing, and that is, I have zero doubts, going to produce, let me put it this way, going to make a difference. And I think what I have heard tonight is a commitment from all of the participants on this panel, is a commitment to make a difference. Not only, as Beth said, you know, to reveal disparate treatment, injustices, historically set up circumstances which perpetuate inequalities and different treatments, but the resolve to do something about that. And to do that in a way which is not going to negate differences that exist. Some of those differences are actually welcomed, but the differences which demean our civilization, which demean each and every one of us who is walking that earth, if we do not do something about that. I'm an economist by training, but a humanist by choice. And I try to usually debunk the notion that economics is a quasi-science which only thinks about the numbers. True economist thinks about the implications of economic decisions that have been made either by him, her, or by the society. The decisions that have been made, as Beth pointed out in the Kozol's book, are definitely decisions which perpetuated inequalities that have been set up in order to take of those who have to take advantage of those who do not have. And the health is actually, in my opinion, health is a synthesis of those inequalities. Because at the end of the day, we will be able to contribute to this world, to our loved ones, to our neighbors, to our community members, to our fellow citizens, to other human beings, as much as we are healthy. If the entire communities are made unhealthy by the unjust arrangements, by the lack of treatment, by the lack of access, then if that is a deliberate design, that it behooves us not only to discover that, which I think we are, but also to, if you wish, undermine the basic fundament of those arrangements. And the basic fundament of those arrangements, we will be able to undo only if we educate each other on one side and then act in accordance on the other side. So thank you for all participants for being here, not only to expose, but also those injustices, but also to have a commitment to the extent that we can, that we do all what we can in order to leave this world a better place for the future generation that we have inherited it. So thank you again, and let us work together in order to make that promise a reality. Thanks.
Thank you, President Schuster, Chancellor Strobel. I'd like to also take this time, of course, to thank our wonderful guests tonight who've been incredibly insightful and thought-provoking for us. Dr. Jameca Cooper, thank you so very much. Dr. Muthoni Musangali, thank you for joining us. And of course, Dr. Fredrick Echols, thank you. I truly appreciate the work that you're doing in the city and throughout the region on behalf of people of color, especially Black folks and those of us who are most marginalized in our care. So thank you for that. I also want to let our audience know that this has been recorded and will be available at www.websterspeaks.edu early next week. We will return on Wednesday, November 17th with I think that actually is the 18th, Thursday, November 18th, with another hot button issue, broken promises, the immigration experience in America. Webster University thanks you, our viewers and donors, for your support of this program and other diversity, equity, and inclusion initiatives. Be safe, good night, and see you soon. Thanks.